are potentially able to discriminate all different phonemes, but after a few months of hearing certain ones, they lose the ability to discriminate other ones, and so you will very likely, if you acquire a language later in life, have an accent that's hard to get rid of. And that's because of the neurological process of pruning, of tuning your nervous system to make certain distinctions and not others. That's an area where we can all see it happening. It's completely plausible, although hard to show at the present time, that there are other kinds of tuning going on. Tuning going on in response to people's affective codes, how they express emotions, the way they use their bodies, physical space, the way that they deal with physiological experiences. So this is the underpinning that we have plausible reasons to think it was there, and then we have on top of that these discursive practices, the way we talk about things, which within any culture only give us a partial picture. The point of a cultural language is to give us an order and an ordering of our life world that reveals some things and hides others. It hides others partly because we simply can't include everything, but it also hides others for particular reasons. So to give you an example of things that have been hidden in our own lives until very recently, we've just been through an extended period of time in which certain kinds of medications, SSRI antidepressants, have become fabulously successful and widely prescribed, and everyone was convinced of their great efficacy. And then just in the last couple of years, as the clinical trials that had been hidden by the pharmaceutical companies were revealed, we discovered that these medications are not nearly as effective as we thought. So here you have an example of a dominant image in society that we have these tremendously useful medications. It's a revolution. We're really going to help people, and a huge deflation suddenly of those claims. And what's more, not just a neutral reason why that wasn't paid attention to, but in fact a very calculated strategy on the part of some of the largest corporations in the world to make huge profits. My colleague Coleman Applebaum in Michigan, who's an anthropologist who studies corporations and who's worked inside pharmaceutical companies, inside pharmaceutical company boardrooms, says that the kinds of discussions you see in pharmaceutical companies are identical to the discussions that you see inside tobacco companies. That the discussion is entirely about how to penetrate the market, how to create need, and how to deliver your product. So I think that this is a very powerful statement about the culture that we live in, and the dilemma, some of the blind spots of the culture that we live in. Last year, we have an annual Advanced Study Institute in Cultural Psychiatry. Last year was on psychopharmacology in a globalizing world, and we talked exactly about these issues, not about the conventional discussion in psychiatry about how might these drugs work at the neurochemical level, but about the larger social forces that are encouraging us to think about things in a certain way, and ways that go considerably beyond whatever scientific evidence we have of what's happening. Now, this is of great interest from a cultural point of view, and it is a global phenomenon. One of the areas that I've done some work in the past is in Japan, and until about 10 years ago, depression was not diagnosed to any great degree in Japan. So much so that when the SSRIs were introduced and took off fantastically in North America, the drug companies decided there's no point in trying to sell them in Japan. There's no market for it. Once they saturated the Western market, then people got interested again and said, okay, we need new frontiers. And they held a couple of conferences. I should say, to my great embarrassment, I was invited and attended one of these, where they invited experts in cultural psychiatry to talk about depression in Japan and how to conceptualize this. And in a few short years, there was a manga created by Yutaka Ono, a Japanese psychiatrist, depicting depression as a kaza no kokoro, a wind, or kokoro no kaza, a wind of the heart, a cold of the heart. It's just like having a cold, you take remedies for a cold, well, you have to take a remedy for this kind of depression. And that was very acceptable to Japanese who have no compunctions in general about using medications. It's not a society that's shy about that. In fact, 6 months after Viagra was released in North America, it was released in Japan. So there was a big rush to get that medication into play. And Japan requires its own clinical trials to release a medication. So there were many hurdles to get through, but the company had planned ahead and it took advantage of that market. Proper way of thinking about the predicament and getting appropriate treatment. Or, in the light of the diminishing returns that we've seen in North America, of labeling a very wide range of dysphoria as major depression and treatment medications, are people over-labeling, over-interpreting, and treating a variety of conditions that impact mental and handle differently? We actually don't know, and it's plausible to think that it's some mixture of those two, and that's exactly the kind of dilemma that we're in right now in trying to understand how culture impacts on our shaping I've used that example, which is again, I'm falling prey to the exoticizing thing of saying, well, let's talk about Japan. Everyone agrees that's a fascinating place and it's far away. However, I'm doing that really because it's much harder to talk about these things in our own society. We're deeply embedded in them. And to question these categories is really to demand a kind of flexibility and kind of standing back from engaged practice that is challenging for all of us. But that's something that we're all very, very concerned with, I should say, in the process of McGill. I'll say 2 more minutes? 3 more minutes. I will make 2.5 more points in 3 more minutes. What I wanted then, having made giving you that anecdote, giving you a little bit of that bigger picture of the international flows of psychiatric knowledge, and tried to suggest to you that if we're thinking about something like depression, we have to understand it as not a description of something that is absolutely out there in the world, as a kind of natural kind, as philosophy call a natural kind of the world, but as something that is carved out of a wide range of different kinds of human problems, collected together and organized by a particular way we have of talking about it and interpreting it. And that's a phenomenon that philosophy in hacking is called the looping effect of human kinds. That is to say, we create a category and we all learn about it, and so we all enact it. It becomes a reality in the world because that's the way we act. In the case of psychiatric disorders, we have what Ian Hacking calls bio-looping. That is to say, it's not just that we're acting this way in the way we do with any social institution. These are the rules we now work by, but that we take these on board in our own way of thinking and feeling and functioning, so they actually influence our biology in significant ways. And so that's even more compelling reinforcement of these experiences. But I want to shift in my remaining 90 seconds to the other very large issue that interacts with this thing. As I've said, looking at these issues in this very broad way, culture as something that pervades all of the work we do, and it requires this kind of very fundamental reflection, also speaks to a more what we can say political problem in everyday life. We live in a highly diverse society. That's true in most parts of the world now. And the idea of how to live together with respect and with full responsiveness to our diversity is a great challenge for healthcare. Some years ago at the Jewish Hospital, we established a cultural consultation service that tries to provide consultations to primary care providers around mental health cases where they feel culture is complicated with care with that patient. But the idea that that kind of reflection will improve the skills of the clinician and will improve the quality of care. And I want to suggest to you, there's not time to make a full argument here, that that kind of taking seriously cultural difference in the clinical encounter is not only good medicine and perhaps even a human rights issue, but also a way of building a pluralistic civil society, which I think is an issue for all of us today all over the world. And many people look to Canada as an exemplar of how to do that. We've done a relatively good job, partly just to be that easier time of it due to our history. We shouldn't pat ourselves in the back too much. But nonetheless, I think we're evolving strategies and ways of doing these things that are helpful to people around the world, and that's why there's great interest in how this works out over the next few years. The Mental Health Commission of Canada, which is currently in the process of developing the mental health strategy for Canada, the only GA country in the world that doesn't have a mental health strategy, has listed 8 basic principles that are just going into a kind of public consultation. And the third of those principles is the idea that the mental health care system will enact a principle of cultural safety. And we've chosen that term rather than cultural competence and so on, to emphasize that in the intercultural encounter, there is a kind of vulnerability. There's the vulnerability of one person, usually a clinician, being dominant in some way and silencing the voice of the other person. And if we take that vulnerability seriously, we're going to pay attention to that unequal power and try to take an active, engage in an active way to give voice, allow the voice of the other. So if you want to pursue any of this further, if you just want to, clearly I said slow down so you could actually critique it in some way, I invite you to, we have an annual summer school, it's the 15th year now of our annual summer program in social and cultural psychiatry. You can't make little pilgrimages from all over the world to attend this. And that goes on for a month of May. Prior to that, this year we have our annual Advanced Study Institute, and the theme this year is child, family, and community mental health in cultural context. We'll be talking both about diverse societies like our own, but also developing countries and the dilemmas of responding to the needs of children with cultural